Start streaming. Oh, coming. What is happening? I'm not. Where am I live now? Am I live anywhere? Can you people hear me and can you people see me? I don't even know this. Where am I live? Okay. Can you people see me? Can you people hear me? Okay, chalo. I am live somewhere. I can't see, but at least I'm live somewhere. Okay. So, uh, now, ha, now, this was the question. This was question number 2, which I was discussing. I have already discussed with you only one question in the previous video, which I am going to now delete because that live session it got interrupted. And this question was double decidual sac sign is seen in, and I told you double decidual sac sign is seen in first trimester. The first ultrasound sign of pregnancy is intradecidual sign, which is due to interstitial implantation, and it is the first sign of pregnancy on ultrasound. It does not tell you whether pregnancy is intrauterine or not. Then comes your double decidual sac sign, where you are going to see an image like this, where the blastocyst or the gestational sac will be surrounded by two rings. The inner ring is going to be of decidua capsularis and the outer ring is of decidua parietalis, right? That is double decidual sac sign. And then comes the double bleb sign, in which you are getting two blebs, right? So two bubbles. Bleb means bubbles. So you are getting two bubbles like these. One bubble is of yolk sac and the other one is of amniotic sac. And whether it is double decidual sac sign or whether it is double bleb sign, both of them indicate intrauterine pregnancy. Now coming to second question, which is again from NEET 2019. What is the ideal time for nuchal translucency evaluation? Remember that nuchal translucency is done between 11 to 14 weeks, and if nuchal translucency comes more than equal to 3 millimeters, that indicates aneuploidy. Which aneuploidy? Most commonly it tells you that there will be a trisomy, most commonly trisomy 21 followed by 18 followed by 13. But then increased nuchal translucency is also seen in Turner's syndrome, and it is seen in cardiac defects. Now, another question sometimes they ask you is, so over here the answer was 11 to 14 weeks. Another question which they can ask you is that suppose nuchal translucency is more than equal to 3 millimeters, what is the next investigation which you would like to do? So nuchal translucency is only a screening test for aneuploidy. I will have to do a diagnostic test for aneuploidy, and the diagnostic test for aneuploidy is FISH or karyotyping. Please remember that if you say that I am going to do, so FISH or karyotyping is the diagnostic test. But suppose you say I am going to do the cell-free fetal DNA. Now, cell-free fetal DNA is a secondary screening test. It is not a diagnostic test. So, if cell-free fetal DNA comes out to be positive, then again it has to be followed by FISH or karyotyping. So, if cell-free fetal DNA comes out to be negative, then you don't need to do FISH or karyotyping. But if cell-free fetal DNA comes out to be positive, still you have to do FISH or karyotyping. Now, suppose your question says that nuchal translucency is more than equal to 3 millimeters and the karyotyping result is normal. What is the next investigation which you would like to do? What is the next step? Now, if karyotyping result is normal, then I am suspecting a cardiac defect, and so then I am going to do a fetal echo. Clear to all of you? Yes? You can't hear me. Someone is saying that I am not audible. Clear? Okay. So this is what you had to know about nuchal translucency. I hope this is very, very clear to all of you. Then comes questions related to induction of labor. Another very, very important topic. And one of the questions was asked in NEET PG 2019. And that is, a 35-year-old female presents to OPD at 41 weeks of gestation. She is very sure about her gestational age. On per-vaginal examination, there is no dilatation, no effacement. What should be done? First thing which I want all of you to remember is that ACOG recommendation. ACOG says that if pregnancy is more than equal to 41 weeks, then termination of pregnancy has to be done. These are new guidelines saying that if pregnancy has reached 41 weeks, you have to go for a termination of pregnancy, but then you have to be very sure that she is 41 weeks, right? So whenever a female comes to you with post-dated pregnancy and they ask you, please remember post-dated pregnancy is more than equal to 42 weeks, and ACOG says that you should not allow pregnancy to go beyond 41 weeks. Now, if your question says a female has come to you with post-dated pregnancy, what is the first step which you have to do? First step which you have to do is you have to ensure that her EDD, you have to, recheck her menstrual history to ensure that the EDD was calculated correctly. And that is why this question is saying that she is very sure about her gestational age. Now, because she is 41 weeks, I have to induce labor. And before inducing labor, what are you going to do? All of you know that you are going to check her Bishop score. A very, very important is what are the parameters of Bishop score? Delhi police employed special commandos, dilatation, position, effacement of cervix, station of fetal head and consistency of cervix. Now, amongst all these 5 parameters, only 2 parameters are given 2 points. PC, Priyanka Chopra is given 2 points, rest all parameters are given 3 points, right? So, position of cervix and consistency of cervix is given 2 points, rest all 3 are given 3 points, maximum score can be 13. If score is less than equal to 5, that's a poor score, so you have to first ripen the cervix. If it is more than equal to 6, that's a favorable score as per the NICE guidelines. And if score is more than equal to 9, that has high chances of a successful induction of labor as per Williams. Now, what are the methods for induction of labor? Quickly revise with me. The first method is Cerviprim gel. This Serviprim gel has dinoproston or PGE2. Serviprim gel, which is available in your labor rooms, it has got 0.5 mg of dinoproston. Now, this image is a new image which all of you should know. This is what is Servidil. Now, in Servidil, again, dinoproston is available, but this dinoproston is 10 mg. In Serviprim gel, it was 0.5 mg. In Servidil, again, dinoproston is available, but it is 10 mg. Serviprim gel was put in the cervix. Here it is put, this Servidil is put in the vaginal fornix, and it has to be removed after 12 hours, or if contractions begin, you have to remove it earlier. Right? Then you can use misoprost for induction of labor. You can use mifepristone, oxytocin, Foley's catheter, or you can go for stripping of membranes and extra amniotic saline infusion. All these are methods for induction of labor. Please remember mifepristone and oxytocin, Foley's catheter, stripping of membrane, extra amniotic saline infusion. These are methods for induction of labor. So in this question, they had given you PGE1 gel, yes, it can be used. PGE2 tablet, yes. Intracervical Foley's catheter, yes. MgSO4, no. MgSO4 is not used for induction of labor. Right? Now suppose your patient is a previous cesarean section patient. In a previous cesarean section patient, we prefer to use Foley's catheter or mechanical methods in comparison to the drugs. Right? So we do not prefer using misoprost or oxytocin or Serviprim. We prefer using mechanical methods for induction of labor in previous cesarean section patient. Clear to all of you? Okay. Then, next question was from NEET PG 2019, where they had asked you which of the following is not a contraindication for induction of labor. Right? So remember, contraindication kya hote hain? Wherever you cannot perform vaginal delivery, that's a contraindication. And read your question very carefully. They are saying which of the following is not a contraindication. So all of you know, if it is herpes genitalis, active herpes infection is a contraindication for vaginal delivery. So obviously I'm not going to go for induction of labor. If there has been 2 LSCS, that's a contraindication. 1 LSCS is not a contraindication. 2 LSCS is definitely a contraindication. Then pelvic tumor is a contraindication. Heart disease is not a contraindication. Right? In heart disease patient, I would prefer that a patient goes into spontaneous labor. But if a patient doesn't go into spontaneous labor, I am going to go for induction of labor. Please remember that maternal contraindications are placenta previa, active herpes genitalis, contracted pelvis, cancer cervix. If there is a classical cesarean section, right, then that's a contraindication for induction of labor. ACOG says that if there is a patient with previous classical cesarean section, then in the next pregnancy you have to do a repeat cesarean, and the repeat cesarean should be done between 36 to 37 weeks. Or if there are previous 2 LSCS. Now, there was one thing which I have erased from here, and that was chronic incision. I hope all of you know what's a chronic incision. LSCS में the most commonly used incision is a Kerr incision. This is what is a Kerr incision, which is a low transverse incision. So when we say LSCS, generally we refer to a Kerr incision. But suppose instead of giving a transverse incision, you have given a vertical incision in the lower segment. Right? This is what is chronic incision. Now earlier it was said that a vaginal birth after cesarean section cannot be tried if there is a chronic incision. Now, the latest ACOG recommendations are that if you have given a chronic incision, then still you can try VBAC. VBAC is vaginal birth after cesarean, or TULAC. What is TULAC? trial of labor after cesarean section. So VBAC or 2 lac can be done in case of chronic incision. Now someone over here, to cur incision you have written phenensteel incision. That's wrong. Phenensteel incision is a low transverse incision which you give on the skin. Skin में when you give a low transverse incision, that is phenensteel incision. When you give a low transverse incision on the lower segment of the uterus, that is Kerr's incision. Right? Yes. Shubham, see again the new Williams which has come, it has specifically now mentioned that few days back ACOG gave its guidelines that if there are previous 3 LSCS, then that's a contraindication to vaginal delivery. Now the new edition of Williams specifically is saying that if there is previous 1 LSCS, then the chances of uterine rupture are less, but if there is a previous 2 LSCS, the chances get doubled. So these guidelines keep on changing. So as per the latest guidelines, which we are following Williams over here, Williams 26th edition, Williams 26th edition is saying that if there is previous 2 LSCS, then also you are not going to go for vaginal delivery. I agree that in my notes I only told you previous 3 LSCS, but the guidelines have changed and now the guidelines are previous 2. पहले previous 2 थी, फिर previous 3 हुई, and again it is back to previous 2. Like I told you, so these guidelines keep on changing. Like I told you earlier, chronic incision was a contraindication for VBAC. Now the latest guidelines say chronic incision is not a contraindication for VBAC. Clear to all of you? Yes? Now, what are the fetal conditions in which induction of labor is contraindicated? So, if there is fetal macrosomia, right, that is going to lead to CPD. So, that is a contraindication. If there is severe hydrocephalus, that is going to lead to CPD. That's a contraindication. Or if there is transverse lie, bro presentation, or in face if it is mento posterior. All of you know in transverse lie, bro, and in face mento posterior, you have to do a cesarean section. And if you are getting non-reassuring fetal heart rate status, now this is something which I want all of you to be very, very careful about. हम हमेशा पढ़ लेते हैं non-reassuring fetal heart rate status. Right? Now, what is this non-reassuring fetal heart rate status? This is what is called as Category 3 CTG findings. Category 3 CTG findings, if you are getting on CTG, it means you have to do a cesarean section. You are not going to go for vaginal delivery. What are those category 3 CTG findings? They are sinusoidal heart rate pattern. So I hope all of you remember what is sinusoidal heart rate pattern. CTG mein if you are getting a wave-like pattern, that is sinusoidal heart rate pattern. So whenever you get sinusoidal heart rate pattern, you have to do a cesarean section. Or if you are getting absent variability with variable deceleration. So if beat to beat variability is absent, and along with that either there is variable deceleration, or there is late deceleration, or there is bradycardia, right? So if you are getting sinusoidal heart rate pattern, you have to do a cesarean section. If beat to beat variability is absent, or it is decreased and you are getting along with that, you are getting variable decelerations or late decelerations or bradycardia, then you have to do cesarean section. I will look at your questions just now. Just give me 2 minutes. Let me complete this thing. Now, suppose your question says that on CTG, you are getting sinusoidal heart rate pattern, or on CTG, you are getting absent variability along with variable deceleration or late deceleration, and they ask you what is the next step. Be very careful. See, best is I am going to do cesarean section, right? But the next step will be that I have to do intrauterine resuscitation. So in sub conditions mein, next step if they ask you, it is intrauterine resuscitation. What do you understand by intrauterine resuscitation? All my marrow students, I am sure You should be able to answer this. Intrauterine resuscitation का मतलब है you are going to turn the patient in left lateral position. You are going to give oxygen by mask. You are going to give her IV fluids, and simultaneously you are going to prepare her for cesarean section. So best is, yes, I'm going to do cesarean section, but in the meanwhile I'm going to go for intrauterine resuscitation. Okay, what is the name of classical LSCS? नहीं होता बेटा, classical cesarean section होता है. Classical cesarean section is Sanger's incision. Okay. I hope you've understood all this. So these are total all contraindications for induction of labor. यहाँ पे there was a confusion to all of you about the score because marrow pearls में कुछ और दिया है and I have taught you different. So remember, marrow pearls is also right. What I have told you is also right. If Bishop score is less than equal to 5, you have to first ripen the cervix. That's a poor score. If score is more than equal to 6, that's a favorable score as per NICE guidelines. But for successful induction of labor, when you are very sure that induction of labor is going to be successful, the score is more than equal to 9. Right? What is modified Bishop score? Modified Bishop score is when instead of effacement, you are checking the length of the cervix, and length of the cervix can be checked by ultrasound. It can be measured on TVS. Right? Okay. This is a very, very important image. I want you to remember Cervidil, right? The drug which is present in Cervidil, and I also want you to remember how much dinoproston is present in Cervidil. It is 10 mg, right? Okay. Then the next topic on which very frequently questions have been asked are maternal adaptations in pregnancy. Physiological changes in pregnancy are very, very important. In NEET 2019 itself, there were 2 to 3 questions on maternal adaptations in pregnancy. So I want all of you to just take a screenshot. All the parameters which are very, very important, I have written them over here. Right? So the parameters which in hematological system, the parameters which increase are blood volume, plasma volume, RBC volume. Because the increase in plasma volume is more than the increase in RBC volume, that is why blood viscosity decreases in pregnancy. This is the reason why PCV, packed cell volume, or hematocrit decreases in pregnancy. Packed cell volume is RBC volume divided by plasma volume. Since the increase in denominator is more than the increase in numerator, so packed cell volume or hematocrit decreases in pregnancy. Now, because RBC volume is increasing in pregnancy, that is why the amount of hemoglobin, that is hemoglobin mass, increases in pregnancy, but hemoglobin concentration decreases during pregnancy, which is measured in grams per DL. Right? Now, lifespan of RBC is slightly shortened in pregnancy. So, and erythropoietin levels and reticulocyte count increases during pregnancy. WBC count increases in pregnancy, but platelet count decreases in pregnancy. This decrease in platelet count is called as benign gestational thrombocytopenia. Please remember that although platelet count will decrease in pregnancy, but it will never come less than normal. So patient के अपने levels से it is going to decrease. It will never be less than normal. All clotting factors increase in pregnancy. That is why pregnancy is a hypercoagulable state. Serum fibrinogen, which is clotting factor number 1. Since all clotting factors are increasing, so serum fibrinogen levels are increasing. And because serum fibrinogen level increases in pregnancy, that is why ESR increases in pregnancy. There are only 2 clotting factors which decrease in pregnancy, and these clotting factors are factor 11 and factor 13. Protein C and protein S decrease during pregnancy. Fibrinolytic activity decreases in pregnancy. Total amount of protein increases in pregnancy. But when we talk about plasma protein concentration, because Plasma protein concentration is grams per dl, so it is going to decrease in pregnancy. Amongst albumin and globulin, globulin increases in pregnancy, albumin decreases during pregnancy. This question will be asked by sex hormone binding globulin. If they ask you what happens to sex hormone binding globulin, all globulins increase, so sex hormone binding globulin will increase. What happens to thyroid binding globulin? It will increase. Now, in case of hematological system, the factors which remain the parameters which remain constant are bleeding time, clotting time, antithrombin time, CD4 is to CD8 count, and B lymphocytes. They remain constant during pregnancy, right? Then in cardiovascular system, cardiac output increases during pregnancy. Cardiac output is stroke volume into heart rate. So stroke volume and heart rate also increase during pregnancy. Because of the pressure of the gravid uterus on inferior vena cava, femoral venous pressure increases in pregnancy, and that is why there are increased chances of varicose veins and hemorrhoids during pregnancy. Now, what are the parameters which decrease? The parameter which decreases is peripheral vascular resistance, because progesterone is a smooth muscle relaxant. So, vascular resistance decreases during pregnancy. This is the reason why BP decreases during pregnancy. The decrease will be seen in both systolic BP and diastolic BP. In cardiovascular system, the parameters which remain constant are jugular venous pressure, pulmonary capillary wedge pressure, and ejection fraction. Right? Please remember, ejection fraction remains normal during pregnancy. Now, in respiratory system, this is the mnemonic which I teach in all my classes. You have to remember in respiratory system the parameters which increase and the ones which remain constant. How are you going to remember the parameters which increase? You are going to remember the mnemonic IC, TV, and movie. So, IC, TV, and movie. IC stands for inspiratory capacity, TV stands for tidal volume, MV stands for minute ventilation. So IC, TV, MV, movie are the parameters which increase. Which are the parameters which remain constant? IRV you have to write horizontally and vertically. IRV stands for inspiratory reserve volume, then respiratory rate and vital capacity. So IRV, respiratory rate and vital capacity, they remain constant. In renal system, renal blood flow increases, GFR increases. So serum urea, serum uric acid and serum creatinine, all of them will decrease in pregnancy. So over here, look, cardiac output increases in pregnancy. Total protein increases in pregnancy. GFR increases in pregnancy. Just now I told you that IRV remains constant. So IRV, residual volume. They're not talking about increased residual. They are talking about residual volume. So just now I told you IRV remains constant. And what are the parameters which increase? IC, TV, and movie. So this means residual volume does not increase in pregnancy. That's the option which is incorrect. Clear? Which of the following decreases in pregnancy? Now, just now I told you IRV remains constant in pregnancy. So that means respiratory rate remains constant in pregnancy. So this is not the answer. Then V stands for vital capacity. It remains constant. It is not the answer. Inspiratory capacity, just now I told you IC, TV, and movie, they increase in pregnancy. So inspiratory capacity is not decreased, it is increased in pregnancy. So the answer over here is functional residual capacity. Clear to all of you? Okay, so over here, see. Respiratory system is very, very important. Just remember ICTV movie. They are the ones which increase. IRV remains constant. इसके अलावा जो भी होगा, everything will decrease. Whatever is left beside these two are going to decrease. IC, TV, movie will increase. IRV will remain constant. Right? This is the way you can remember the respiratory changes which are happening during pregnancy. Very, very important. Right? Then, which of the following is true about vaginal changes in normal pregnancy? So, which of the following is true? So, number one, decreased number of lactobacilli. In pregnancy, what is happening? In pregnancy, the number of lactobacilli will increase, right? And what are these lactobacilli? These are doddeline bacilli, which are going to increase, which are going to convert more of glycogen into lactic acid. So, there will be increased glycogen metabolism. Yes. Now, because doddeline bacilli are increasing and they are converting more of glycogen into lactic acid, so vaginal acidity will increase. In other words, pH is going to decrease. So, that's the wrong option. Then there is epithelial thinning. No. In pregnancy, there is epithelial thickening. There is epithelial thickening and there is increased vascularity. What is this increased vascularity called as? It gives a bluish color to the vagina and cervix, and that is what is called as Chadwick sign or Jack-Mears sign. Another thing which you have to remember is there are increased cervical secretions during pregnancy, and these secretions are very thick and they form a mucus plug. Right? So, vaginal pH decreases during pregnancy. Lactobacilli will increase in pregnancy. Pathogenic bacteria will decrease in pregnancy because the environment is getting, vaginal pH is decreasing because of the acidity, vagina becoming more acidic, pathogenic bacteria will decrease. The only one pathogenic organism which can survive in acidic media is Candida. That is why most common vaginitis during pregnancy is candidiasis. Right? Now, all of the following are normal physiological changes in pregnancy except option A, left axis deviation, option B, mild ST changes in inferior lead, option C, atrial and ventricular premature contractions, and option D, pansystolic murmur. So, which is physiological except? Tell. Piyush is the first one to answer this. Honey is also the second one to answer this, and both of them are saying the answer is option D. And yes, the answer is option D, because during pregnancy you get an ejection systolic murmur or a continuous murmur. Please remember, the signs which are normal in pregnancy these are the cardiovascular signs which are normal in pregnancy. So JVP, it remains constant during pregnancy. Heart rate increases, so pulse rate increases in pregnancy. BP decreases in pregnancy, that's normal. Two murmurs are absolutely normal. Ejection systolic murmur less than grade 3/6. All of you remember ejection systolic murmur, but you tend to forget less than grade 3/6. Then a continuous murmur, that's a mammary murmur which is heard in the second and the fourth intercostal space. S1 during pregnancy is loud and it is widely split. S2 is normal, and S3, which is not easily heard during pregnancy, is easily heard. On X-ray, you will get mild cardiomegaly, which is normal. In ECG, left axis deviation of 15 degrees is normal because the diaphragm is going to push the heart up and out. So, a left axis deviation up till 15 degrees is normal. Mild ST changes which you are getting in inferior lead is normal. Atrial and ventricular premature contraction is normal. Remember, in ECG, there won't be any change in voltage during pregnancy. In echo, you will see that there can be mild tricuspid regurgitation during pregnancy. That's normal. There is increase in left ventricular mass. So, if you are a Marrow subscriber and just in case these points you have not highlighted, please highlight that in echo, tricuspid regurgitation is normal in pregnancy. Slight increase in left ventricular mass is normal during pregnancy. Ejection fraction remains normal in pregnancy. These echo findings and ECG findings, all of you, I want you to remember them. Right? So these are the normal ECG and echo findings which are included in Williams 26th edition. Please note them in your notes and revise them. So this question was easy even if you didn't remember the ECG findings, or because you know by exclusion, you know that a pansystolic murmur is not normal in pregnancy. It is ejection systolic murmur which is normal in pregnancy, right? So by exclusion, this is normal. Is bradycardia in pregnancy always pathological? So yes, if you are getting bradycardia, that will be pathological because heart rate normally is increased in pregnancy. Clear? Now, so these were the questions which came in from the topic maternal adaptations in pregnancy. And as you can see, what trend I have noted these days is the examiner takes up one topic, and from those one topic they give you 2 to 3 questions. So in 2022 it was PIH, and on PIH you had 2 to 3 questions. Then in 2021 it was bleeding in early pregnancy, abortion, ectopic, and questions were there from abortion and ectopic. In 2019 it was maternal adaptations in pregnancy. There were 3 questions from maternal adaptations in pregnancy, right? Questions from amniotic fluid and placenta are very, very simple. You won't have any problems in answering them. The question was major contributor for amniotic fluid post 20 weeks, and I'm sure all of you know that post 20 weeks the major contributor is fetal urine. Right, in the first trimester the major contributor is maternal plasma. Between 12 to 20 weeks it is fetal skin, and at more than equal to 20 weeks it is fetal urine. Maximum amniotic fluid, it is seen at 34 weeks. The range is 32 to 34 weeks, right? Then again a very simple question which came from amniotic fluid. Generally from amniotic fluid you get simple questions, and that is a 22-year-old primary gravida who's sure of dates visit antenatal OPD. On further obstetrical examination her uterine height is 16 weeks. Obstetrical ultrasound shows reduced LICA. What is the probable cause? So all of you know that since your major contributor is urine, and if there is renal agenesis, there is going to be oligohydramnios. Fetal anemia, what does that lead to? Fetal anemia leads to polyhydramnios. Barter's syndrome is one fetal renal condition in which you get polyuria, and because of polyuria you get polyhydramnios. So in fetal anemia also there is polyhydramnios, and in Barter's syndrome also there is polyhydramnios. So whether they are asking you, hydrops fetalis also leads to polyhydramnios, right? Now coming to diabetes in pregnancy. In diabetes in pregnancy, one question came in NEET 2019, and the question was, you discover that there is evidence of cardiac malformation in a fetus during a routine ultrasound scan at 16 weeks. What is the minimum level of fasting blood sugar at which you can suspect overt diabetes? That's a pretty simple question. All of you know that overt diabetes, when do you get overt diabetes? When do you say there is overt diabetes? When fasting blood sugar levels are more than equal to 126, and that is what you've done in your medicine also. So fasting blood sugar levels more than equal to 126, or random blood sugar or 2-RPP value if it is more than equal to 200, or HbA1c more than equal to 6.5. This is the diagnostic criteria for overt diabetes. Overt diabetes is called as pre-gestational diabetes. Now for gestational diabetes, I want all of you to note, because this was asked in INI set, it has not yet been asked in NEET, but please remember this criteria for gestational diabetes also. Gestational diabetes के लिए in India the criteria what we are using is DIPSI criteria. Whether it is overt or whether it is gestational, in India we are following DIPSI criteria. But for gestational diabetes, the international criteria, which is according to IADPSG and ADA. ADA is American Diabetes Association. IADPSG is International Association of Diabetes and Pregnancy Study Group. So according to IADPSG and American Diabetes Association, you have to do a GTT. And this GTT you are going to do between 24 to 28 weeks, right? Fasting is needed and you are going to give 75 grams of glucose. After giving 75 grams of glucose, you are going to note the fasting levels, 1 RPP levels and 2 RPP levels. Please be very careful of these levels. Upper limit of fasting is 92, upper limit of 1 hour is 180 and 2 hour is 153. 92, 180, 153. So this is IADPSG criteria or American Diabetes Association criteria for diagnosing gestational diabetes. You have to remember how much glucose is given. 75 grams glucose is given. Is fasting needed? Yes. And at what time are you going to do the test? Between 24 to 28 weeks. How is it different from DIPSI? DIPSI, which is being used in India, for dipsing, no fasting is needed, number one. Then dipsy says you have to do this test twice, one at the first antenatal visit and then you have to repeat it between 24 to 28 weeks. Again, I am going to give 75 grams of glucose, right, in 300 ml of water, and I'm going to check her blood sugar levels after 2 hours. If after 2 hours blood sugar levels are less than 140, she doesn't have any diabetes. If they are more than equal to 140, she has gestational diabetes. More than equal to 200, then overt diabetes, right? So IADPSG criteria mein fasting was needed. Here fasting is not needed. IADPSG criteria mein you have to do the test only between 24 to 28 weeks. DIPSI says you have to do the test twice, right? IADPSG mein you have to note the fasting levels, 1 hour levels and 2 hour levels. Yahan pe you have to note down only the 2 hour levels. So after 2 hours of giving 75 grams of glucose, you have to check her blood sugar levels, right? Now, so quickly revise what are the metabolic goals in diabetes. Now, whether your patient is on diet modification, which is also called as, quickly tell me what is the new name for diet modification? MNT, medical nutrition therapy, right? So whether your patient is on diet modification or whether your patient is on insulin, metabolic goals are the same for overt diabetes and for gestational diabetes. The metabolic goals are fasting sugars should be less than 95, 1 RPP should be less than 140, 2 RPP should be less than 120, average capillary glucose should be less than 100 and HbA1c should be less than 6. Please remember, metabolic goals mein HbA1c should be less than 6. For diagnosing overt diabetes, HbA1c is more than equal to 6.5. Clear to all of you? Yes? Then, next question, again in NEET PG. This was an image based question. They had shown a baby, and NEET PG is very fond of showing you pictures of babies, right? So over here what you are seeing such a healthy baby and such chubby cheeks. The weight of the baby is looking more than what is, normally you get for newborn babies. So this was a baby was born at 34 weeks. See, 34 weeks baby and such a healthy baby. The appearance of the baby is given below. What is the mother suffering from? So what do you think this baby has? This baby is having macrosomia, and so I am thinking that the mother is suffering from gestational diabetes. Please remember, if they ask you what is the most common neonatal complication of diabetes, the most common neonatal or fetal complication of diabetes is macrosomia. That is the most common fetal complication of diabetes. It is seen both in gestational diabetes and in pre-gestational diabetes. How do you define macrosomia? Macrosomia is, in Indian context, if weight of the fetus is more than equal to 4 kgs. What are the risk factors for macrosomic babies? Gestational diabetes or overt diabetes, pre-gestational diabetes, male fetus. So this condition is more common in male fetus. Post-dated pregnancy, if mother has gained more weight during pregnancy or before pregnancy also she was obese, and multiparity. So these are risk factors for macrosomia. If you have attended my GSOC classes, or if you are a Maro student, I have shown you a picture of a very chubby baby, and in the side I have made you write risk factors for macrosomia. I have also made you write that how do you diagnose macrosomia? You can diagnose macrosomia with the help of abdominal circumference of the fetus. If abdominal circumference is more than equal to 35 centimeters, that indicates macrosomia. Now, ACOG recommends vaginal delivery for macrosomia. ACOG says only if the weight of the baby or the fetus is more than equal to 4.5 kgs in diabetic patients or more than equal to 5 kgs in non-diabetic patients, then you have to go for cesarean section. Very, very important ACOG recommendation, right? एग्जाम में मैक्रोसोमिया के लिए यू आर गोइंग टू मार्क 4 kgs. In India, our national guidelines, see, wherever our national guidelines are available, we follow our national guidelines. Wherever our national guideline is not available, then we follow ACOG guidelines. Right? And for this, our national guideline is available. Diabetes pe very specific guidelines are available. So we are going to mark the answer as more than equal to 4 kgs. Clear? Okay. Then, as I told you, your NEET PG student, this was NEET 2020 question. Now, what condition in the mother is associated with the following fetal anomaly? So, over here, what do you think? What is the anomaly which you are seeing over here? What is this anomaly? Macrosomia causes again. So the risk factors are diabetes in the mother. It could be gestational or pre-gestational diabetes, male fetus, post-dated pregnancy, maternal obesity or increased weight gain by the mother during pregnancy, and multiparity. Right? Now, coming to this image, tell me, what are you seeing in this image? In this image, I am seeing that the sacral area of the baby, the lower limbs of the baby, they are not well developed. There is sacral agenesis, right? This is what is caudal regression syndrome or sacral agenesis. And tell me, congenital malformations are seen in which kind of diabetes? Congenital malformation is seen in pre-gestational diabetes. It is not seen in gestational diabetes. So over here, my answer is going to be pre-gestational diabetes mellitus. Remember that the most specific anomaly which is seen in congenital malformation, which is seen in overt diabetes, is sacral agenesis. But which is the most common one? This is sacral agenesis is most specific. Most common is, which is the most common congenital anomaly which is seen in babies of diabetic mother? VSD. Right? If VSD is not given in the options, then neural tube defect. Right? Which is the most specific cardiac anomaly which is seen in babies of diabetic mother? Most specific cardiac anomaly. Quickly tell me in the chat box. Most common is done. Now tell me most specific cardiac anomaly. हो गया. VSD, NTD is done. Now tell me which is the most specific one. Excellent. Excellent. TGA. Okay. Now tell me another question. Most common cardiac change which you see in babies of diabetic mother. So cardiac change or cardiac lesion. This question is going to come in the form of lesion. Most common cardiac lesion which is seen in babies of diabetic mother. I'm writing it over here so that you can see. My next question to you is most common cardiac lesion. Most common cardiac lesion seen in babies of diabetic mother. That is HOCM. Excellent. What is the difference between lesion and anomaly? Lesion is reversible. Anomaly is not reversible after birth. Right? So if they ask you most common cardiac lesion, it is HOCM. Now I want you to compare these two images. In image A, you are seeing that it is the lower limbs where the developmental problem is seen. In this image, what you are seeing that it is both upper limbs and lower limbs where you are getting proximal amputation of the limbs of both upper limb and lower limb, right? So if they give you this image, this is not sacral agenesis. Here it is, the problem is in upper and lower limbs, and it is in there is proximal limb defect, right? So if you are getting proximal limb defect, then this proximal limb defect, it is seen when a mother ingests thalidomide during pregnancy, and this is what is called as phocomelia. So this was sacral agenesis. This is phocomelia, right? Now, a very, very important question which they ask you on diabetes and where you tend to get confused is, what is the time at which I am going to go for induction of labor in diabetes? So, in case of diabetes, if it is A1 diabetes, A1 diabetes means gestational diabetes which is controlled on diet. So if it is a gestational diabetes which is controlled on diet, then you are going to terminate pregnancy at more than equal to 39 weeks, and it can go up till 41 weeks. So between 39 to 41 weeks, you are going to terminate her pregnancy. If it is A2 gestational diabetes, what is the difference between A1 and A2 gestational diabetes? A1 gestational diabetes means it is controlled on diet. A2 gestational diabetes का मतलब है that you are using some drug to control the diabetes. That drug could be insulin, that drug could be metformin. Because in gestational diabetes, although the drug of choice is insulin, but if patient refuses to use insulin, I can use metformin. Right? So whether I am using insulin or metformin to control gestational diabetes, if the gestational diabetes, that is what is A2 diabetes. Now, if A2 diabetes is well controlled, then again the termination of pregnancy has to be done at 39 weeks, right? And you may do it up till 40 weeks. But if it is A2 gestational diabetes and it is not well controlled, right, then the termination has to be done between 37 weeks to 38 weeks. Similarly, if it is pre-gestational diabetes and it is well controlled, the termination has to be done at 39 weeks. So simple funda yaad rakhoge. Simple funda is well controlled diabetes. चाहे वो diet पे well controlled हो, that becomes A1. Well controlled diabetes, gestational diabetes on drug, right, that is A2. Or whether it is overt diabetes which is well controlled. Well controlled hai, so the termination of pregnancy has to be done at 39 weeks. If it is not well controlled, right, then you have to do it between 37 to 38 weeks plus 6 days. Clear to all of you? Yes, so do not get confused in this, right? So these were the questions which have been asked in your previous years on diabetes in NEET. Then questions which have been asked on PIH. Now, a pregnant woman with no other comorbid condition develops preeclampsia. She inquires about the cause of her condition. The doctor explains it is due to failure of invasion of. This was a question which came in NEET 2022. Right? So tell me. I want all of you to quickly see this diagram. I am not explaining a lot in detail over here. So in this diagram, you can see this is a spiral artery. Spiral artery is present in decidua and it is present in myometrium. and the spiral artery has a very narrow lumen. It is narrow. Now during pregnancy, what happens is cytotrophoblast replaces the lining of the spiral arteries of the decidual part also and the myometrial part also, and it makes it into dilated vessels so that the resistance which is offered by spiral arteries is less. Now this work is done by a special type of cytotrophoblast which is called as extravillous cytotrophoblast. So extravillous cytotrophoblast will replace the lining of these spiral arteries and make them into dilated vessel. It will replace the lining of the decidual part also and myometrial part also. Extravillous cytotrophoblast में भी एक स्पेशल पार्ट होता है which does this work, and that is endovascular cytotrophoblast. So either in your options it will be written as extravillous cytotrophoblast or endovascular cytotrophoblast, right? Now it is going to replace the lining of the decidual part of the spiral arteries by 12 weeks and myometrial part by 16 weeks. In patients in whom PIH has to develop, the second step doesn't happen. So as you can see over here, the decidual part lining has been replaced, but myometrial part's lining is not replaced, right? Another very important, and this is what is called as incomplete trophoblastic invasion. That means the myometrial part of the spiral artery, their lining is not replaced by extravillous cytotrophoblast or endovascular cytotrophoblast. Now, what are the cells which play an important role in trophoblastic invasion? The cells which play an important role in trophoblastic invasion are natural killer cells, maternal natural killer cells, right? So over here, spiral artery, the doctor explains that it is due to failure of invasion of spiral arteries by villous trophoblast. No. Radial arteries by cytotrophoblast. No. Spiral artery by extravillous trophoblast. Yes. Right? So the answer here is option C. It wasn't an easy question, but in marrow I have explained you in detail about pathophysiology of PIH. Pathophysiology of PIH in NEET still it is uncommonly asked, but in your INI set they are very fond of asking about questions on pathophysiology of PIH. Right? Next question, which was again in NEET PG 2022. And this question was, a woman with an obstetrical score of G2P1 comes at 14 weeks of gestation for her antenatal checkup. A uterine artery Doppler was suggested by the Doppler. What would it detect? Right? Now, please remember that in pregnancy, whenever they are saying uterine artery Doppler can only detect PIH, that is preeclampsia, or IUGR. Right? So it is used for prediction of PIH or IUGR. Right? Then comes middle cerebral artery Doppler. Middle cerebral artery Doppler is used in Rh negative pregnancies when their indirect Coombs test is positive. Right? Then if I have to follow up such an Rh negative pregnancy, I'm going to use middle cerebral artery Doppler. And the third Doppler is umbilical artery Doppler. Like uterine artery Doppler could predict PIH and IUGR, umbilical artery Doppler helps in knowing the prognosis of PIH and IUGR. Right? So coming to uterine artery Doppler, how does uterine artery Doppler predict PIH? So normally in a uterine artery Doppler, you see, and this is something which we've done in detail, you see a diastolic notch, and this diastolic notch usually disappears by 22 to 24 weeks. If this diastolic notch persists beyond 22 to 24 weeks, then it means this female is going to have PIH in this pregnancy. right? This is one way of knowing that this patient is going to have PIH, that is persistence of diastolic notch. Another way is if there is increased pulsatility index in the uterine artery Doppler, then that also tells that this patient is going to have PIH. Normally, uterine artery Doppler, to predict PIH, the time for doing the Doppler is 22 to 24 weeks. But a recent study which was done in AIMS, it showed that if you do uterine artery Doppler between 11 to 13 weeks, and if you see that the pulsatility index is high, then it predicts that this patient is going to have an early onset preeclampsia, right? So this, but routinely we don't do uterine artery Dopplers to predict PIH or IUGR, but then early onset preeclampsia can be predicted by doing uterine artery Doppler early. Clear? Okay. Then, so the answer over here is, if you are doing uterine artery Doppler at 14 weeks, that means you are checking her for early onset preeclampsia. So the answer is option A, right? Then comes a type 1 diabetic patient who is on magnesium sulfate post cesarean section for preeclampsia, develops delirium and drowsiness. She has a respiratory rate of 10 per minute. Her random blood glucose level is 240. There is oliguria and bilaterally absent knee reflex. What is the cause of her condition? Is it magnesium sulfate toxicity, or is it diabetic ketoacidosis, eclampsia, or diabetes insipidus? So definitely it's not diabetes insipidus, since patient is not throwing any convulsions, so it is not eclampsia, right? Now I have to choose between magnesium sulfate toxicity and diabetic ketoacidosis. Please remember that for diabetic ketoacidosis, the levels at which diabetic ketoacidosis is going to happen will be between 350, right? So yeah, it will be between 350 to 500, and over here the blood sugar levels are 240. So at 240 you are not going to have diabetes, the patient is not going to have diabetic ketoacidosis, right? In diabetic ketoacidosis, a patient presents to you with dry mouth, thirstiness, shortness of breath, increased urinary frequency, and flushing, right? And whenever there is diabetic ketoacidosis, you have to give her NS or ringer lactate. Clear to all of you? Now coming to magnesium sulfate toxicity. About magnesium sulfate, remember it's an anticonvulsant. It is not an antihypertensive. It is centrally acting and it has got a very low therapeutic range. The therapeutic range of magnesium sulfate is very, very important, 4 to 7 milliequivalents per liter. What are the signs of magnesium sulfate toxicity? The first sign is loss of knee jerk, which happens at whenever the magnesium concentration is more than 10 milliequivalents per liter. Number 2 is decreased respiratory rate. This will later be followed by respiratory paralysis and arrest. And this is going to happen when magnesium concentration is more than 12 milliequivalents per liter. Then patient can have diaphoresis, slurring of speech, flushing. Cardiac conduction defects will be seen whenever there is more than equal to 15 milli, when magnesium is more than equal to 15 milliequivalents per liter, right? Remember, oliguria को हम check करते हैं for magnesium sulfate toxicity, but oliguria is not a sign of magnesium sulfate toxicity. Whenever I have to give magnesium sulfate, I will check her knee jerk, I will check her respiratory rate, and I'm going to check her urine output. But I am checking her urine output because magnesium sulfate is excreted via kidney, right? So if there is oliguria, there are chances of magnesium sulfate toxicity, but oliguria is not a sign of magnesium sulfate toxicity. Oliguria leads to magnesium sulfate toxicity. So in this case, patient has come to you with delirium and drowsiness. There is oliguria, there is bilaterally absent knee reflex, and her respiratory rate is decreased. All this indicates that there is magnesium sulfate toxicity, right? Then about magnesium sulfate, please remember the Pritchard regime of magnesium sulfate, which says that the loading dose is 4 gram IV 20% and 10 grams IM 50%. The Magnesium sulfate which is available in your labor room is a 50% solution. It is a 2 ml ampule. इसका मतलब क्या हुआ कि in 2 ml there is 1 gram of magnesium sulfate, right? So 1 ampule is a 2 ml ampule, and because it has 50% magnesium sulfate, so each ampule is 1 gram. इसका मतलब ये हुआ that if a patient of eclampsia is coming to me and I have to pick up magnesium sulfate ampules for loading dose. So for loading dose, how many ampules I'm going to pick up? 4 ampules I'm going to pick up for IV dose, and 10 ampules I'm going to pick up for IM dose. So total number of ampules which I'm going to pick up will be 14, right? Whenever you are giving loading dose, there is no need to measure the renal function, and maximum how much magnesium sulfate can you give flow rate for IV? Maximum IV you can give 1 gram per minute, right? Now, as I am telling you that when you have to give IM, you have to give 50% solution. So I have to give 10 grams IM 50% solution. So I will pick up 10 ampules. 5 ampules I am going to give in one buttock. 5 ampules I am going to give in left. 5 ampules in right buttock. Right now, when I have to give IV, I have to give a 20% solution, but the ampule which is present in your labor room is 50% solution. This question came in your NEET 2020. Just now I'll show you the question. So in NEET 2020, they asked you that if you have to give IV dose, how is the IV dose prepared? How are you going to prepare the IV dose? I am going to take a 20 ml syringe. In that 20 ml syringe, I am going to put 4 ampules of magnesium sulfate. So when I am putting 4 ampules of magnesium sulfate, I am putting 8 ml magnesium sulfate, that is 4 grams magnesium sulfate. Now I am going to add normal saline 12 ml. 12 ml normal saline. This means that now in 20 ml solution there is 4 gram magnesium sulfate. Now there is 20% magnesium sulfate, and this has to be given 1 gram per minute. Clear to all of you? Please remember, जब हम loading dose देते हैं, you don't have to measure the renal function. Right? Maintenance dose is 5 gram IM 50% in alternate buttock, and this has to be repeated after every 4 hourly. How long do you have to give the maintenance dose? Maintenance dose should be given till 24 hours after the last seizure, or till 24 hours after delivery, whichever is later. Right? And whenever you are giving maintenance dose, you are picking up how many ampules? 5 ampules of magnesium sulfate. And before giving the maintenance dose, what are the 3 things which you are going to check? Number 1, you are going to check urine output. Number 2, knee jerk. And number 3, respiratory rate. Clear? So this solves one more question which was asked in NEET 2020, that how is the IV dose of magnesium sulfate prepared? Right? Loading dose is very easy, beta. Loading dose में you have to give 10 grams maintenance dose, 10 grams IM and 4 grams you have to give IV. अब जो 10 gram IM देना है, that is 50% solution, and that is what you have in your labor room. You have a 50% magnesium sulfate in your labor room, and 1 ampule of magnesium sulfate has 1 gram magnesium sulfate, 2 ml of magnesium sulfate. Right? 2 ml में 50% होगा, तभी तो 1 gram magnesium sulfate होगा. So 2 ml has 50%, that is 1 ampule has 1 gram magnesium sulfate. So when I have to give IM, I am going to pick up 10 ampules. Right? 10 ampules means 10 grams, 50% solution. Right? I am going to give 5 grams in each buttock. Now, I am also going to give the loading dose of the IV dose. For IV dose, I need 20% solution. 4 grams, 20% solution. So, in order to prepare that 20% solution, I will take a 20 ml syringe. In this 20 ml syringe, I am going to add 4 ampules of magnesium sulfate. When you add 4 ampules of magnesium sulfate, Actually, you are putting 8 ml of magnesium sulfate. In other words, 4 grams of magnesium sulfate. Right? Now to this, I will add 12 ml of normal saline. अब बताओ, टोटल कितना वॉल्यूम हो गया? वॉल्यूम हो गया 8 plus 12, that is 20 ml. Is 20 ml में how many grams of magnesium sulfate is there? 4 grams. In other words, you have 20% solution. This much maths you can do. कि if in 20 ml there is 4 grams, तो 100 ml में कितना हुआ? 20%. Right? Clear? Okay. Now, next question in NEET 2019, magnesium sulfate has no role in. This is a very easy question. You are going to tell me quickly. Prevention of seizures in severe preeclampsia, prevention of recurrent seizures in eclampsia, prevention of respiratory distress syndrome in premature baby, reducing the contractility of uterus. So, it is used for prevention of seizures in preeclampsia. It can be used for prevention of recurrent seizures in eclampsia. Then it is used for reducing the contractility of the uterus. So magnesium sulfate has tocolytic action, and the tocolytic action of magnesium sulfate occurs between 9 to 10 milliequivalents per liter. Right? But it is not used to prevent RDS in premature baby. For preventing RDS, you have to give corticosteroid. राइट मैग्नीशियम सल्फेट का एक और रोल होता है, दैट इज न्यूरो प्रोटेक्शन इन प्री मेच्योर बेबीज. सो इन प्री मेच्योर बेबीज इट प्रिवेंट्स cerebral palsy. It prevents cerebral palsy. So the answer over here is option C. Clear? Next question, NEET 2021. For a female with hypertension on preconceptional counseling, which drug should be avoided? So which drug has to be avoided in a case of PIH? Which antihypertensive has to be avoided? They have given you option labetalol, methylphenidate, ACE inhibitors, and I'm sure all of you know that ACE inhibitors are contraindicated during pregnancy. So ACE inhibitors, angiotensin receptor blockers, that is losartan, beta blockers and diazoxide. These are the drugs which are contraindicated in pregnancy. These are antihypertensives which are contraindicated in pregnancy. Right? Clear to all of you? Now, I just want all of you to quickly remember that in case of PIH, the New Williams says that if there is mild PIH, there is no need to give antihypertensive. There is no need to give antihypertensive. In case of severe PIH, there is no drug of choice. There are 3 drugs and you can use any of these 3 drugs. You can use labetalol, you can use hydralazine, or you can use nifedipine for managing severe PIH. Methyl dopa, these are first line drugs used for managing severe PIH. Methyl dopa is a slow acting drug, so it is not the first line drug for managing severe PIH. Now, the New Williams also says that if your patient has overt hypertension, that is chronic hypertension, if your patient has chronic hypertension, then you have to choose between methyl dopa, labetalol and nifedipine. Right? In that case, hydralazine is not the first line drug, right? So these are the first line drugs for chronic hypertension. Right? Clear to all of you? Yes, methyl dopa is the safest antihypertensive, but now the New Williams says that there is no drug of choice for chronic hypertension. They are first line drugs. You can choose either methyl dopa or labetalol or nifedipine. In severe PIH, you will use labetalol IV hydralazine or oral nifedipine. Right? Okay. Next question, NEET PG 2022. There was one more question which I wanted to show you. This was the question which was asked in 2020 NEET. A 35-year-old primi gravida conceived after IVS cycle attends antenatal checkup at 38 weeks period of gestation. Her obstetrical details revealed a DCDA twin with first twin as breech. On examination, BP is more than 140/90 on 2 occasions with proteinuria +1. How do you manage? So because her BP is more than equal to 140/90 on 2 occasions, right? So this means that she is a case of mild PIH or mild preeclampsia because she has proteinuria. So she is a case of mild preeclampsia. Now in case, so this is a question where you have to use concept of twin and PIH. In case of mild preeclampsia, at what time do you terminate her pregnancy? You terminate her pregnancy at more than equal to 37 weeks. Now this patient is already 38 weeks. This means I have to go for termination of pregnancy. Right? Now, because I have to go for termination of pregnancy, now I have to think whether I should go for vaginal delivery or cesarean section. PIH in itself is not an indication for cesarean section. But read the question carefully. They are saying it is a dichorionic diamniotic twin pregnancy and first twin is breech. Now, because first twin is breech, I cannot do vaginal delivery. So, I have to do a cesarean section. So my answer becomes immediate cesarean section. Now instead of DCDA, right, if they would have given monochorionic monoamniotic twins. Monochorionic monoamniotic twins, the moment they give you this option, right, monochorionic monoamniotic twins में you don't even have to see कि first twin breech है या first twin cephalic है. Monochorionic monoamniotic twin means you have to do cesarean section. And at what time do you do cesarean section in monochorionic monoamniotic twins? Between 32 to 34 weeks. Why? Because there is one complication which happens in monochorionic monoamniotic twin which does not happen in any other twin pregnancy, and that is cord entanglement. Cord entanglement. Right? Okay. Now, whenever you people feel that you want me to end this session, I can end this session and I can take it up again tomorrow. If you want, I can continue it continuously till 8 o'clock, 9 o'clock, till the time all the questions are there. We don't finish all the questions, I can take it up. Whatever you people feel comfortable, I'll do that. Right? So be very, very careful whenever you get questions like these. DCDA में you have to do cesarean only if first twin is breech or if first twin is transverse lie. Okay, next question. NEET PG 2022 question. A patient with normal BP, normal coagulation profile, has AST ALT 75 international units, LDH 400, platelet count 75,000. What is the diagnosis? Now, in this case, you are getting a condition where the liver enzymes are increased, platelet count is decreased, right? So, this is what is HELP syndrome, right? This is what is HELP syndrome. I can see some of you writing it as acute fatty liver of pregnancy. It is not acute fatty liver of pregnancy. I'll tell you just now. So this is HELP syndrome. Please remember, in HELP syndrome, the problem which I know which you are feeling is that they are saying normal BP. So remember, in 85% cases in HELP syndrome, BP will be increased. But in 15% cases, BP of the patient is going to be normal in HELP syndrome. Right? In HELP syndrome, the criteria which is used for diagnosing HELP syndrome is Tennessee's criteria. According to Tennessee's criteria, there has to be hemolysis plus elevated liver enzymes plus low platelet count. Elevated liver enzymes you can come to know by any two of the following. If peripheral blood smear is showing you schistocytes or helmet cells or Burr cells. If bilirubin levels are high, if LDH levels are high, or if you are getting severe anemia unrelated to blood loss. Then elevated liver enzymes to 2 times the normal values and platelet count less than 1 lakh. So over here LDH value is high. It is not very high, but still the LDH value is raised. Platelet count is decreased. AST ALT level is increased. That is why I am saying it is HELP syndrome. Why it is not acute fatty liver of pregnancy? It is not acute fatty liver of pregnancy because in acute fatty liver of pregnancy, it is not just hepatic failure which you get, you also get renal symptoms, right? So they will say that kidney function tests are deranged. Number one, they are going to tell you that coagulation profile is deranged. They are going to tell you ammonia levels are high. They are going to say there is hypoglycemia. So whenever you are getting, so whenever they say that the liver function is deranged, ammonia levels are high, there is hypoglycemia, renal function is deranged and abnormal coagulation profile, then you have to think about acute fatty liver of pregnancy. If simply liver function is deranged and you are getting low platelet count, then it points towards HELP syndrome. Over here LDH was high, liver enzymes were high and platelet count was decreased, so it was HELP syndrome, right? Why is it not uh, cholestasis? In cholestasis they are going to say serum bile acids are high, right? And why it is not hepatitis? In hepatitis, AST ALT, the liver function will not just, the SGOT SGPT levels will not just be 75 international units, they will be very very high, right? So it is not a case of acute hepatitis. Clear? Then a next question which came in NEET 2019 is, which of the following statement, itching. In case of cholestasis in pregnancy, the most common symptom with the patient is going to come to you will be itching. And please remember, whether it is acute fatty liver of pregnancy, whether it is cholestasis, or whether it is HELP syndrome, all three of them are going to present in third trimester, right? Now, which of the following is correct about acute fatty liver of pregnancy? It occurs in 1 in 1000 pregnancies. No, it is not this common. It is a very rare condition which occurs in 1 in 7000 to 1 in 20,000 pregnancies. It is mostly seen in last trimester. Yes. It is common in female fetus. No, it is common in male fetus. It may be associated with decreased uric acid. No, here the kidney function is deranged, so you are going to get increased uric acid. So what is the etiology of acute fatty liver of pregnancy? Quickly revise it with me. In acute fatty liver of pregnancy, there is deficiency of L-CHAD enzyme. That is an enzyme which is needed for oxidation of long chain fatty acids. So mainly there is a deficiency of L-CHAD enzyme which is needed for oxidation of long chain fatty acids. There is also deficiency of M-CHAD enzyme which is needed for oxidation of medium chain fatty acids. Now, this deficiency is present in fetus, because of which there is accumulation of long chain fatty acids in the fetal liver, and there is accumulation of long chain fatty acids in the liver of mother as well. When you do histopathological examination of the liver in mother, you are going to see that there is microvesicular fatty infiltration. This is the most common cause of liver failure in pregnancy. Acute liver failure in pregnancy ka most common cause is this acute fatty liver of pregnancy. It is also called as the yellow atrophy of liver. It is more common in male fetuses like PIH. It is more common in primigravida females. Please remember one thing. HELP syndrome is more common in multigravida females. PIH and acute fatty liver of pregnancy is more common in primigravida females. Then acute fatty liver of pregnancy is more common in twin pregnancy and if there is preeclampsia or HELP syndrome. In 20 to 40% cases of HELP syndrome, you will get associated acute fatty liver of pregnancy. Patient, as I told you, is going to present in third trimester with nausea, vomiting. When you are going to do her liver function, her LFT will be deranged. The liver enzymes will be raised to 5 to 10 times their normal value. Serum bilirubin will be more than equal to 5. Ammonia levels will be very high. That is why patient is going to present to you with confusion or delirium. There will be hypoglycemia. KFT will be deranged. So serum uric acid, serum creatinine, everything will be increased. Then in your question, if you are getting a picture which is very similar to HELP syndrome, but your question says that patient has pancreatitis or diabetes insipidus. Pancreatitis or diabetes insipidus agar hai, to then it is acute fatty liver of pregnancy. It is not HELP syndrome. In HELP syndrome, coagulation profile generally remains normal. In case of acute fatty liver of pregnancy, you get abnormal coagulation profile. Now, in whether it is acute fatty liver of pregnancy or whether it is HELP syndrome, management is immediate termination of pregnancy by induction of labor, right? So many of you are saying that we should continue it tomorrow. I will upload this PDF, but uh, why are you so impatient? Let us complete it today only. It will take some time, but let's complete it today. What do you say? No, ma'am. Okay, let me just do a little bit more, right? You are NEET PG bachas. You have to learn how to sit for longer time than FMGs. I will provide session of this PDF. Okay, coming to a question where you are going to for of bleeding in early pregnancy on abortions. So, a pregnant lady with history of recurrent abortions is now diagnosed to have antiphospholipid syndrome. This question came in 2019. This is NEET 2019 question. What would be the best mode of treatment for her? So this is a patient is being diagnosed with APLA syndrome. You have to tell the best mode of treatment for her. Tell me. A pregnant lady with history of recurrent abortions has APLA syndrome. What is the management? Now, if you follow me on Instagram, this was the question which I took up around 2-3 days back. Now, whenever there is APLA syndrome, first let us see how do you diagnose APLA syndrome. APLA syndrome can be diagnosed by the modified Sapporo's criteria, or it can be diagnosed by Sydney criteria, which says that there should be one clinical or one lab criteria to diagnose APLA. In clinical criteria, it is more than equal to 3 fetal losses which are happening at less than 10 weeks, more than equal to 1 fetal loss which happens at more than 10 weeks, 1 preterm labor which is happening due to early onset preeclampsia or IUGR, or if there is history of venous or arterial thrombosis. Out of these 4, if any one is present, that means clinical criteria is fulfilled, right? So, fetal loss at less than 10 weeks, 3. Fetal loss at more than 10 weeks, 1. 1 preterm labor due to early onset preeclampsia or IUGR or venous or arterial thrombosis, right? Then 1 lab criteria. In the lab criteria, out of the 3 antibodies which are present in antiphospholipid antibody syndrome, that is lupus anticoagulant, anticardiolipin antibody, or beta-2 microglobulin antibody, any one antibody should be present on 2 occasions 12 weeks apart. So out of these 3 antibodies, any one antibody should be present on 2 occasions 12 weeks apart. Then we say that the lab criteria is fulfilled, right? Now, once I have diagnosed my patient with APLA syndrome, now comes the management part. Now, if your patient has APLA antibodies and she has history of abortions, then the treatment which you have to give her is heparin and aspirin. Please remember, aspirin should be started as soon as pregnancy is diagnosed, and heparin should be started once intrauterine pregnancy is confirmed. right? Now, if your question says that APLA antibodies are present and there is history of thrombosis, then also the management is heparin and aspirin. But if your question says that there are APLA antibodies are present and patient has been diagnosed with APLA because of history of preterm labor, in that case you have to give only aspirin. Or if your question says that the clinical criteria is not getting fulfilled but APLA antibodies are present, then also you have to give only aspirin. Why am I giving anticoagulants to patients of APLA? Because although the name is lupus anticoagulant, but all these APLA antibodies, they lead to thrombosis. And that is why we have to give anticoagulants, right? So now your question was saying that there is a pregnant female with history of recurrent abortions along with APLA diagnosis. So APLA diagnosis and history of abortions, what are you going to give her? You are going to give her heparin and aspirin, right? Okay. Now, this was a question which created a lot of controversies. This came in 2020. In NEET 2020, and it created a lot of controversies. A 30-year-old G4P3 had first pregnancy loss at 8 weeks, second loss at 11 weeks with no cardiac activity, then a third preterm delivery due to early onset preeclampsia. The diagnosis is. Now, please remember, torch infections can never lead to recurrent abortions, right? A controlled diabetes will also never lead to recurrent abortions. Uncontrolled diabetes leads to recurrent abortions, right? So now I am left between, I have the option to choose between syphilis and APLA. Now all of you know that syphilis follows Kazowitz's law. According to Kazowitz's law, whenever a patient in syphilis is going to have a pregnancy loss, with each subsequent pregnancy loss, the period of gestation at which the loss occurs will increase, right? So in case of syphilis, if initially patient is having an abortion, next time she is not going to have an abortion, she is going to have preterm delivery. Then next time a patient of congenital syphilis is going to have stillbirth. And then next time she is going to have low birth weight, and then next time a normal child. This is what is called as Kazowitz's law. In case of syphilis, you are never going to get that she is having 2 first trimester abortions. This kind of history you will never get in syphilis, right? So it cannot be syphilis. It is a case of APLA, although they haven't mentioned APLA antibodies are present. But this, number one, because they are saying pregnancy loss is happening in first trimester, and just now I told you to diagnose APLA, 3 or more than 3 pregnancy losses have to happen before 10 weeks, 1 pregnancy loss at more than 10 weeks. I also told you preterm delivery due to early onset preeclampsia. This kind of line, this wording which you are getting is typical in APLA. In APLA, you get preterm delivery due to early onset preeclampsia or IUGR. So this is a case of APLA. It is not a case of congenital syphilis. Congenital syphilis follows Kazowitz's law, where you are going to have in the first pregnancy miscarriage, in second pregnancy preterm delivery, in third pregnancy stillbirth, then low birth weight, and then a normal child. Right? Clear? So this is APLA. Next question. NEET PG 2022. A 20-year-old woman presented at 7 weeks of gestation, unwilling to continue the pregnancy. What are the drugs used for medical termination of pregnancy in this patient? I'm sure all of you know that for medical abortion, you are going to use mifepristone and misoprost. This is a screenshot from our national guidelines for medical abortion. Why I have made this, I have clicked this screenshot is to clear one point to you, because at so many other platforms this point is not given correctly, and you people are keep on asking me that ma'am you have taught this, elsewhere it is taught this ways. So this is a direct screenshot from our national guidelines. So up till 7 weeks, you are on day 1, you have to give mifepristone 200 milligrams oral, and then you have to wait for 24 to 48 hours. On day 3, you are going to give misoprost 400 micrograms, right? This is if you are doing abortion up till 7 weeks, and in India it is recommended to do up till 7 weeks, right? But you may do it between 7 to 9 weeks also. So if you are doing abortion between 7 to 9 weeks, again on day 1 you have to give 200 milligrams of mifepristone, but now on day 3 you have to give 800 micrograms of misoprost. And whether you are doing abortion up till 7 weeks or between 7 to 9 weeks, on day 15 you have to call the patient to check for the completeness of the process. Right now, whenever you are doing medical abortion, please remember, ultrasound is not mandatory. This is one thing which you keep on asking me, because in Marrow I have told you, you don't have to do an ultrasound. It is not mandatory when you go for medical abortion. I don't know where you people are studying that an ultrasound is mandatory to perform medical abortion, and you keep on asking me this question. So our national guidelines say it is not mandatory to perform ultrasound before performing medical abortion, only if you are suspecting ectopic pregnancy. And when do you suspect ectopic pregnancy? If your patient is saying she has irregular vaginal bleeding, or she has pelvic pain, or she has an adnexal mass or tenderness. In that case, when I'm suspecting ectopic pregnancy, then I have to do an ultrasound. Otherwise, it is not mandatory to do ultrasound at any time. Even when patient is coming to you on day 15, if the bleeding has stopped, then I presume that the entire product of conception has been expelled out. Only if she is bleeding when she is coming to me on day 15, then I expect that no, the product of conception is still inside the uterus, and then I may do an ultrasound to check it. Right? So at no point of time during medical abortion is ultrasound mandatory. Another thing which I want you to note is, when can you give an additional dose of misoprost? If you have given misoprost for medical abortion and within half an hour of taking oral misoprost your patient vomits, then you have to give repeat dose of misoprost. If there is no vaginal bleeding even after 24 hours of giving misoprost, then again you may give her a dose of misoprost. A third condition where you can repeat a dose of misoprost is if your patient has excessive bleeding during the process of abortion, you may give her misoprost to control the bleeding, and if still the bleeding is not getting controlled, then in that case you have to go for surgical evacuation. Right? So these are all very important points related to medical abortion. So over here the answer is misoprost and mifepristone. Pretty simple question. Next question, again, which was on abortions, and it was asked in NEET 2022. A 40-year-old female G2P1 at 18 weeks of amenorrhea comes with dilated cervix. The cervical length is 15 millimeters. In spite of explaining the risk, she insisted on cerclage. Which of the following is a contraindication for cervical cerclage? Right? Now, please remember, cerclage is another very important topic where you tend to get confused. Cerclage is done in two conditions in OBS. One in case of cervical incompetence and one in case of preterm labor. Right? So if I want to prevent preterm labor in that case. So in case of cervical incompetence, when I do a cerclage, if I am getting history of 2 second trimester abortions, then even without doing any ultrasound, I go for cervical cerclage. That is one. Number two, if I am getting history of 1 second trimester abortion and I do a TVS and the length of the cervix comes less than equal to 2.5 centimeters, then that indicates I have to do a cervical cerclage, right? In both these situations, number one and number two, just now the cervix has not started dilating, right? This is I am doing to prevent cervical incompetence. And when am I going to do the cerclage? Between 12 to 14 weeks, right? Sometimes what happens, a patient of cervical incompetence, they already have a dilated cervix, and with a dilated cervix I have to do a cerclage. That is what is called as emergency cerclage or rescue cerclage, right? If the cervix has already started dilating and you are doing a cerclage, that is rescue cerclage or emergency cerclage, right? Now, no matter when you are doing cerclage and for what indication you are doing cerclage, you are not going to do a cerclage if bleeding is present, if membranes are ruptured, if infection is present. By infection I mean if there is chorioamnionitis, if any infection is present, or PID, if some vaginal infection is present, if contractions are present, or if fetus has gross congenital anomalies, right? So in these conditions I am not going to go for cerclage. These are contraindications for doing cerclage. A relative contraindication for doing cerclage is placenta previa. Clear to all of you? In case of preterm labor, to prevent preterm labor, when do I do cerclage? If I am getting history of very early preterm labor, so patient tells me that there was a preterm labor which happened at less than equal to 24 weeks and I did a TVS and I saw that the length of the cervix was less than 2.5 centimeters. Then in that case we do cerclage. Please remember, ACOG guidelines say, and practically also we do cerclage only maximum up till 24 weeks. But sometimes they specifically ask you, ki what does RCOG guidelines say? RCOG guidelines say that cervical cerclage can be done up till 28 weeks, right? So unless and until they specifically ask you about RCOG guidelines, you are not going to say that. Remember, ACOG guidelines and practically also हम cerclage करते हैं only up till 24 weeks. Earliest you can do cerclage between 12 to 14 weeks. Clear to all of you? Yes. So they are saying, which of the following is a contraindication? Now over here in this patient, the cervix is already dilated and the length of the cervix is 15 millimeters, which means that she is a case of cervical incompetence and I am going to perform rescue cerclage or emergency cerclage. What are the contraindication? Ruptured membrane, yes, it is a contraindication. Prolapse of membranes into vagina, no, that's not. Ruptured membrane is a contraindication. Prolapse of membrane in vagina is not a contraindication. Fetal fibronectin protein positive, that means preterm labor. Again, preterm labor is not a contraindication. Advanced maternal age, that's not a contraindication. So ruptured membranes is a contraindication. Now, bleeding in early pregnancy में ectopic pregnancy. Questions which were asked on ectopic pregnancy. This was a very simple question which was asked, simple yet a little tricky, which was asked in 2022, NEET 2022. A primigravida at 22 weeks of gestation presents to you with profuse vaginal bleeding. Her BP and glucose levels are within normal limit. Placental implantation at which of the following sites can cause this? Now tell me. If you are dealing with ectopic pregnancy of ovary and abdomen, will it lead to profuse vaginal bleeding? No, it does not lead to profuse vaginal bleeding. So that cannot be the answer. Now, if it is fallopian tube, although the most common site for ectopic pregnancy is fallopian tube, but do you think an ectopic pregnancy which is happening at the fallopian tube can persist up till 22 weeks? No, it cannot persist up till 22 weeks. It has to end maximum by 12 weeks, right? So this means my answer by exclusion is internal os, right? Next question, which was again a NEET 2022 question. A female presents to you with 6 weeks of amenorrhea, abdominal pain and vaginal bleeding with normal BP. Now, when they say normal BP, that means a ruptured ectopic is excluded, right? Because when it is a case of ruptured ectopic, most of the times your patient will be in shock. Most of the times, right? Investigation revealed beta HCG 1400 international units. Ultrasound showed trilaminar endometrium with normal adenexa. They haven't mentioned anything about GSAC. So this is empty uterus. They haven't said that any sign of pregnancy can be seen inside the uterus, right? What is the next best step in management? So whenever a patient comes to you with abdominal pain, bleeding, right, and there is history of amenorrhea, so in that case, the first thing what you are going to do is a TVS or an ultrasound. Now on ultrasound, if you are not seeing anything, no sign of pregnancy is being seen, then empty uterus, if you are getting empty uterus. Now this empty uterus could be due to abortion, it could be due to ectopic pregnancy, or it could be due to an early viable intrauterine pregnancy. So in order to differentiate between them, I'm going to measure beta HCG levels. Please remember, ectopic pregnancy may, if your question says that on ultrasound you are getting a G-sac plus a yolk sac in fallopian tube, this is a sure shot diagnosis of ectopic pregnancy. If your question is saying this is seen and they ask you what is the next step is medical management. Because best management for ectopic pregnancy is medical management. But suppose your question says that there is empty uterus, or your question says that a G-sac is present in fallopian tube, they haven't said anything about yolk sac, or your question says an adnexal mass is present, right? In either of these three cases, they are not confirmatory findings for ectopic pregnancy. So in any of this, the next step is you have to measure beta HCG. Now, because your question hasn't said anything, it means it's empty uterus. And whenever you are getting empty uterus on ultrasound, the next step is beta HCG measurement. In beta HCG, the critical titer of beta HCG for TVS is 2000 international units. If values are more than 2000 international units and you are getting empty uterus, it means your ectopic pregnancy is confirmed. But if the values are less than 2000 international units, then you are going to repeat beta HCG after 48 hours. If the values of beta HCG nearly double, when we say nearly double, that means the increase is more than equal to 55%. That means it is a viable intrauterine pregnancy. If the values increase but the increase is less than 30%, that is a slow rise, then that means it is ectopic pregnancy. Or if values decrease, that means it's a case of abortion. Right? So in this case, there was empty uterus. Patient came to you with abdominal pain, bleeding, and there was 6 weeks of amenorrhea. On ultrasound, there is an empty uterus. They haven't mentioned anything which they can see, right? So the next step was HCG. On HCG, they are saying the values of HCG are 1400 international units, which means it is less than the critical titer. So now what I have to do? I have to repeat beta HCG after 48 hours. Right? Clear to all of you? Okay. Next question. This was a question which came in 2021 NEET. Now, a 30-year-old female who was on treatment for infertility with 6 weeks of amenorrhea came with abdominal pain and vaginal bleeding. Abdominal pain is the most specific symptom for ectopic pregnancy. Her beta HCG was 2800 international units. On ultrasound, a left adnexal mass was seen. A gestational sac with no fetal cardiac activity was seen on annexation. What is the most appropriate management? So, सबसे पहले coming to the first thing. This is a case where again you are getting abdominal pain, amenorrhea and bleeding, right? So the first thing is you should do a TVS. On TVS, the finding which is confirmatory for ectopic pregnancy is G-sac and yolk sac, right, in the tubes. But in this case, what you are getting? In this case, you are getting only a G-sac or you are getting an adnexal mass. Just now I told you, if you are getting only a G-sac or if you are getting an adnexal mass, that is not confirmatory for ectopic pregnancy. And whenever it is not confirmatory for ectopic pregnancy, what is the next step? Beta HCG measurement. So over here, beta HCG has already been done and they are saying it is 2800 international units. 2800 international units means it is more than the critical titer. If it is more than the critical titer and still I cannot get a G-sac inside the uterus, it means it's ectopic pregnancy. So now I'm sure I'm dealing with a case of ectopic pregnancy. Now I have to do the treatment. Now for treatment, as I told you, the best treatment always is medical management. Now how to decide whether to do medical management or not? So remember, always you have to decide between medical management and surgical management. Expectant management बहुत rarely is going to be your answer. First, let us see how do we decide between medical management and surgical management. Medical management is done only if the vitals of the patient are stable. Surgical management can be done in stable as well as unstable. Unstable, why? Ruptured ectopic mein you can do surgical management, right? Now, if the vitals of your patient are stable and you are thinking about medical management, but your question says that family of the patient is complete. If family of the patient is complete, again, you should prefer surgical management. You shouldn't prefer medical management. Third thing, look at the HCG values. For medical management, HCG values should be less than 5000. If HCG values are more than 5000, you should go for surgical management. Fourth thing, you should look at the size of the gestational sac. If size of the gestational sac is less than 4 centimeters, go for medical management. If it is more than 4 centimeters, go for surgical management. Right? Is the live session still on? But can you all hear me? Can you all hear me? Acha, acha. Okay, you can hear me. Okay. Then comes cardiac activity. If cardiac activity is absent, then medical management should be done. If cardiac activity is present, preferably you should be doing a surgical management. Cardiac activity, if it is present and if I do medical management, chances of failure of medical management are high. So, see, presence of cardiac activity is not a contraindication for medical management. But if cardiac activity is present and if I go for medical management, then the chances that medical management will fail will be high, right? This is one thing. Now, suppose I tell my patient that cardiac activity is present. So, I will not do your medical management. I will do surgical management. And she says, no, doctor, please go for medical management. I refuse surgical management. So, in that case, if cardiac activity is present and you are doing medical management, then the size of the sac should be less than 3.5 centimeters and not 4 centimeters. Clear to all of you? Now, in your question, they are saying that the size of the sac is 3 centimeters, number one. Number two, her HCG values are 2800 international units and she's a case of infertility. That means her family is not complete. All these three things go in favor of medical management. So I am going to go for medical management. In ectopic pregnancy, medical management is done by giving single dose of methotrexate, right? So single dose therapy of methotrexate, that is what I am going to do. All clear? And there is no cardiac activity. Again, that goes in favor of medical management. Now, expectant management you should do only and only if the levels of HCG are less than 200 international units, the values are spontaneously decreasing, and you cannot see any G-sac in the tube on ultrasound. Right? So in that case, you have to go for expectant management. Otherwise, always medical management is the best answer for management of unruptured ectopic pregnancy. Milking of the tubes, it is not done these days. Milking of the tubes, what they were used to do was that if this is ectopic, they used to squeeze the tube so that the ectopic pregnancy, it comes out from the fimbrial end. This is not done these days now. Right? Clear to all of you? Coming to the next question, which came in NEET PG 2019. And the question is, gestational trophoblastic neoplasm includes all except option A, invasive mole, option B, partial mole, option C, placental trophoblastic tumor, option D, choriocarcinoma. Right? So tell. So remember, gestational trophoblastic diseases we have molar pregnancy and gestational trophoblastic neoplasias. In molar pregnancy, it is partial mole and complete mole. In gestational trophoblastic neoplasias, we have invasive mole, choriocarcinoma, placental site trophoblastic tumor and epithelioid trophoblastic tumor. So this was a very easy question. Partial mole is not included in gestational trophoblastic neoplasms, right? Which is the most common GTN after molar evacuation? The most common GTN after molar evacuation is invasive mole. Do not say choriocarcinoma. Right? What is the chromosome number of a partial hydatiform mole? Again, a very straightforward question. In case of partial mole, there is an ova which is fertilized by 2 sperms. So it is dispermic. The chromosome number of partial mole is triploid. It is 69. Most common is 69XXY. The most common karyotype which you get is 69XXY. In a complete mole, which is also called as vesicular mole or hydatiform mole, there is an empty ova which is fertilized by a single sperm and then the chromosome number of the single sperm duplicates. So it is monospermic, it is diploid and the chromosome number is 46XX. That's the most common karyotype. You people tend to remember the uncommon karyotypes and you forget the most common karyotype. Please remember, most common karyotype for partial mole is 69XXY and for complete mole is 46XX. Clear to all of you? Yes. Now a very important question which came in 2021 NEET, and again it created a lot of confusion, right? So over here, methotrexate ki dose for ectopic pregnancy is 50 milligram per meter square, right? You have to give 50 milligrams per meter square. Okay. Now, this question is a very interesting question. It says a woman who has undergone dilatation and curettage for molar pregnancy 6 months ago presents with persistent symptoms of abdominal pain and distension. On further investigation, so after 6 months also her beta HCG levels are high. There is cannonball foci which was present on chest X-ray. So what do you think? What has this patient developed? She has got now cannonball metastasis, which means she has developed gestational trophoblastic neoplasias. right? Now, since she has developed gestational trophoblastic neoplasia and I have to treat gestational trophoblastic neoplasia, so first of all, I'm going to do staging of GTN. Now, staging of GTN is, stage 1 of GTN is when GTN is limited to the uterus. Stage 2 का मतलब है कि GTN has spread to the visceral pelvic structures, for example, vagina. Stage 3 means when there is lung metastasis. This lung metastasis can be confirmed on chest x-ray. On chest x-ray, the most common appearance which you get is a cannonball appearance, and the second most common appearance which you get is the snowstorm appearance. And stage 4 means distant metastasis to liver or to brain, right? Now, ab GTN ko, there are two things which you have to do. Whenever you have diagnosed a patient with GTN, first thing is you are going to stage the GTN according to FIGO staging. Now, according to FIGO staging, your patient in this question is, she has developed cannonball foci. This means she is stage 3 GTN, right? Now comes why are we worried about staging? Because although GTN is chemosensitive tumor, whether it is choriocarcinoma, whether it is invasive mole, both of them are chemosensitive and the treatment of choice is chemotherapy. But I have to decide whether I have to give single drug therapy or I have to give multi-drug therapy. Right? Whenever it is stage 1 GTN, always you have to give single agent, and that is you have to give methotrexate. Always if it is stage 4 GTN, where that means the metastasis has happened to lungs or to liver or to brain, you have to give multi-drug chemotherapy. Right? Now, what about stage 2 and stage 3? How am I going to decide whether I have to give single agent or whether I have to give multi-drug? For that, we use WHO's risk scoring system. So this WHO risk scoring system is very, very important. There is a very detailed table which is given in all your textbooks, but you don't need to remember that. Remember what I'm telling you over here. This is what I've told you in Marrow in my GSOC classes as well. So if age of the patient is less than 40 years, she's low risk. If more than 40 years, high risk. If the antecedent pregnancy was molar pregnancy, it's low risk. If it was full-term pregnancy, it's high risk. If the antecedent pregnancy happened at less than 4 months, then it is low risk. If it happened at more than 12 months, it's high risk. If HCG value is less than 10 to the power of 3, it's low risk. More than 10 to the power of 5, high risk. If the size of the tumor is less than 3 centimeters, low risk, more than 5 centimeters, high risk. Number of metastases less than 4, low risk, more than 8, high risk. If metastasis has happened to lungs and vagina, low risk. If it has happened to liver and brain, high risk. If there is history of previous failed chemotherapy, low risk. If there is no history of previous failed chemotherapy, low risk. If history of previous failed chemotherapy is present, high risk. So if you will look at this broadly, you just have to remember, take a sheet of paper, stick it on your wall and read it 2 to 3 times. You will understand what is low risk, what is high risk. Now WHO says you are going to do a scoring system, and if the total score comes less than 6, it means low risk. If it comes more than equal to 7, then it is high risk. So in case of stage 2 and stage 3, I am going to see whether my patient belongs to WHO's low risk category or high risk category. If my patient belongs to WHO's low risk category, I am going to give methotrexate. If she belongs to high risk category, I am going to give multi-drug chemotherapy. Understood? तो स्टेज 1 फीगो है तो हमेशा सिंगल ड्रग methotrexate therapy. So you have to give only methotrexate. Stage 4 है तो हमेशा you have to give multi drugs. Stage 2 and stage 3 में you have to calculate WHO's risk. If it is low risk, single drug methotrexate. If it is high risk, multi drug. Right? The other difference which you have to remember is, in case of ectopic pregnancy, when you were giving methotrexate, you were giving single dose methotrexate therapy. In case of GTNs, whenever you give methotrexate, you give multi-dose methotrexate. Multi-dose methotrexate का मतलब है हम day 1 पे देंगे, day 3, day 5, day 7, and then in between it will be alternated with folinic acid, right? Okay. So, see your question. So first of all, tell me, your patient is belonging to which stage according to FIGO? According to FIGO, because your patient has lung metastasis, she belongs to stage 3. If she is stage 3, I need to see whether she is belonging to low risk category or to high risk category. So number 1, this patient is having GTN after molar pregnancy. If she has GTN after molar pregnancy, she comes in low risk category. She is having GTN after 6 months of molar pregnancy, right? If it would have been more than 12 months, it would have been high risk. If it is 6 months, it is somewhere in between low and high risk, right? Then the metastasis has happened in lungs. As I told you, lung metastasis means low risk. So overall, the picture which I am getting is that this patient is a low risk GTN, stage 3. She is stage 3 low risk choriocarcinoma patient. And if she is low risk choriocarcinoma patient, I am going to give her methotrexate. I am not going to give her multi-drug therapy. The multi-drug therapy which you give in case of choriocarcinoma or GTN is EMACO regime. EMACO regime. EMACO regime में E stands for etoposide, M stands for methotrexate, A for actinomycin D, C for cyclophosphamide, and O for oncovin, right? So are you going to give her EMACO? No. Are you going to do hysterectomy? No. Are you going to give methotrexate with folinic acid? Yes. So I have to give multi-dose methotrexate on day 1, day 2, day 3, day 5 and alternating with folinic acid. Yes, this is a tricky question. Clear to all of you? Yes? Yeah, fourth option was single dose methotrexate. You never give single dose methotrexate in GTN. Single dose methotrexate is given in ectopic pregnancy, right? The other thing which I want you to remember is, if your question is talking about PSTT or about epithelioid trophoblastic tumor, in PSTT and epithelioid trophoblastic tumor, you have to do hysterectomy. Hysterectomy is done in PSTT and in ETT, epithelioid trophoblastic tumors. Right? Okay. So it is 7:45. Let me finish this session over here only. About antepartum hemorrhage, postpartum hemorrhage, questions on labor and gynae part. Again, it is going to take 2.5 hours and I will complete it tomorrow. Right? Yeah, too much for today. So I'll complete the rest of the session tomorrow. Again, same time, 5 o'clock. We meet tomorrow. Maybe I change the time. If I change the time and I do it in the afternoon session, then I'll update you on my Instagram handle. So do not forget to subscribe to my Instagram handle. If there is a change in timing, I will inform all of you on my Instagram handle. But as of now, the session will be at 5 o'clock tomorrow. Okay, take care. All the best to all of you. Keep preparing. You all will really do very well, but don't stop and don't quit at this time. Right? Okay.